So shall we start? It's already 1 o'clock.
Okay, I'll get started. Can you hear me?
Yes. Yes, you can.
Yes. Excellent. Okay, so Assalamu alaikum, everyone. Welcome to today's event. Imamia Medics International UK and EU, in conjunction with Sadiq International Virtual University, would like to welcome you to the event today. We have a public health webinar, updates on COVID-19 and the vaccine. And I'm Dr. Hussein Shabi from Sadiq International University and from Imamia Medics UK, and I'll be moderating today. I'm going to share the agenda. Here's our agenda today. So we decided to carry out today's webinar as we felt this is a good time and a good opportunity for this information as the vaccine rollout increases internationally around the world. In the UK, there's been a very successful vaccine rollout. 60% of adults have had their first dose, and that's mainly the older population, and gradually we're getting to those who are younger, including, for example, those of childbearing age. And so we felt this is a good time to talk about the vaccine before Ramadan as well. So today we'll start with Dr. Zainab Mukhtar, and she'll discuss updates on the COVID vaccine. That will be followed by Dr. Fatima Hussein discussing COVID-19 fertility and pregnancy. There'll be time to ask questions after each talk, so please do post any questions in the Q&A section on Zoom, and I'll envisage to ask them. So I'll start by introducing our first speaker, and that's Dr. Zainab Mukhtar. It's an honor to have her. Dr. Zainab Mukhtar is based in Germany and is part of IMI EU. She works at an international diagnostic company, and she studied in Karachi and did postgraduate qualifications from the Bristol Institute of Transfusion and Transplantation Sciences. She's a trained assessor from Paul Ehrlich Institute in Germany for marketing authorization of biologics. She's been working in hematology, immunology, and blood banking for 15 years and has been working on the COVID-19 diagnostics and the impact on hematology parameters. So welcome, Dr. Zainab Mukhtar. I'll hand over to you.
So thank you very much. And I will try to share my screen. So do you see my screen now?
Yes.
Yep, we can see your screen.
I have to change the display settings, I think. So is it okay now?
Perfect.
Okay, so thank you very much for giving me the opportunity to present something about the situation of the COVID-19 and also the vaccines. So I will start with the objectives of today's presentation. So we will talk something about the statistics of the current situation of the disease, and my focus will be on vaccination. So I will present some statistics related to the vaccine. Then I will talk about the vaccine types, which are right now authorized, and what is the situation in EU and also in UK. So just keeping in mind that I will cover both the Europe and the UK situation and the statistics as well. I will talk something about the side effects which are reported by MHRA so that we have an idea about these questions, because people are worried about the side effects of the vaccines. I will touch upon some of the vaccines which are not right now in UK and in Europe, but in some other parts of the world, and we keep traveling. And we also get questions related to those vaccines. I will touch upon variants of COVID-19 as well, and what protection the vaccinations can give us from the variants as well. So coming to the statistics at the moment, globally, the statistics tells us that almost 1.3 million, 1.35 million confirmed cases of COVID-19 are there globally at the moment, and which has caused around 2.9 million deaths. This is the statistics as per 9th of April. So according to the people who have received the vaccine, at least one dose of the vaccine, these are the vaccine statistics which you see on the screen. So this is what the disease is at this stage right now in the world, and these are the vaccination efforts that have happened in different countries. And you can see this is the statistics of how many people, share of the people who have received at least one dose of COVID vaccine. So it depends on the countries, it depends on the number of people in the country, this is clear. But at the same time, it also depends on the marketing authorization of the vaccine system in that country, and how the vaccine agreements have been made with the authorizing agencies. It is not only about regulators, but it is about the peers as well. So there are many factors that play role here, and you can see that the situation is right now. So depending on the population, for example, the doses of the vaccines are very high in India, but you can see according to the population, it is very low even now. So this is the COVID-19 vaccine doses that are administered per 100 people. I'm showing the statistics because for vaccination, to understand the reach of the vaccinated people, it is important to see how many vaccines doses were administered per 100 people. So these are the statistics you can see, and definitely it depends again on the population of the country, it depends on the outreach, it depends on the vaccination agreements that you have, it depends on the regulatory approval in your country as well. So you can see according to the number of people and the people that are covered with the vaccine, at least one dose per 100 people. So these are the countries that are going very high in their outreach of vaccine to people. Israel is number one and UAE is number two at the moment. UK is not bad, it's around 56%. So I would say this is like out of 100 people, 56 is a very good number. Then we come to the vaccine types. So I would like to discuss about the types of vaccines that are currently in the market and also in the developmental stages. So vaccine development is a complex process, and we are all familiar with it because we have been vaccinated since birth for several diseases, and sometimes we also get vaccinated when we travel. So vaccines are of different types, and depending on the type of vaccines, there are certain pros and cons of the vaccines based on the developmental part of the vaccine. So some vaccines are made up of live viruses, for example, polio vaccine. Some vaccines are made up of inactivated viruses. I'm trying to keep my language simple, understanding the fact that people may be coming from different backgrounds, but you can definitely ask more questions if you want. Some vaccines are made up of the DNA, which is the genetic material inside the cell, or the RNA, which is also the genetic material inside the cell. Some vaccines are made up of the pure DNA and RNA, and some vaccines are made up of the cultured DNA or the RNA, or we can say recombinant DNA or the RNA. And they have their own pros and cons, because when you construct DNA and RNA, there are several things that you need to take into account depending on the virus or the protein for which you are making the vaccine. Some vaccines are protein based, means they are not using the whole DNA and RNA, but they are using some protein fragments of the virus or some protein particles to elicit the immune response. Some vaccines are made up of vectors like a transport system which transports the viral gene into your body. And that transport system or the transport vector is made up of another virus or another or another protein or another molecule which transmits the virus into the body. So they are known as viral vector-based vaccines. Some vaccines are made up of peptide molecules, small molecules of proteins, and they are also again for different viruses, but they have certain advantages and disadvantages depending on the types of proteins that are included in the vaccine. So vaccines are made depending on three situations in the world. One is how much urgent the situation is. So the methodology is designed based on the urgency of the situation because it's a long process. The second thing is how is it a virus, which type of virus it is, and how it attacks the body. And the third thing is how often does it replicate? What are the replicability features of the virus? And the fourth is the stability of how do you maintain the stability of the vaccine once it is induced in the body. So there are many factors that play role in the vaccine development, and therefore the manufacturers design vaccines based on these factors. Whenever the manufacturers design vaccines, there are certain guidelines that the FDA and the other regulatory bodies have, that vaccine should be this much safe, it should be this much efficient, it should be this much uh, useful after being given to the people. So these guidelines set up certain thresholds for efficiency and efficacy of the vaccines. And when the trials are being conducted, these efficiency and efficacy measures are taken into account. And based on that, the vaccines are given marketing authorization. So every regulatory body in countries like EU has EMA, UK has MHRA, FDA is there in US. Similarly, different countries have different regulatory bodies, but most of the bodies tell that 50% should be the effectiveness of a controlled trial when the vaccine does the controlled trial. So it's not, when we look at 50%, it doesn't look very promising. It doesn't say it's 90%, but it starts from 50%. And after reaching the 50%, they look into some other things related to the efficacy of the vaccine as well. So this is how they are monitored, and they are continuously monitored and evaluated for their safety as well, both in EMA, European Medical Agency, and also in MHRA. So which are the vaccines that are authorized for use in the European Union at the moment? I'm talking starting from European Union, and then I will go to UK as well. So we have here Pfizer and BioNTech vaccine, which is authorized for use. I'm saying authorized for use does not mean it's a full authorization. It can be emergency use authorization or conditional marketing authorization. So when we talk about different types of authorizations of vaccines, these terminologies are based on certain conditions, certain timelines, and these timelines are monitored based on the data from the manufacturers which is coming, and continuously these timelines are updated as well. We have Moderna, which is also a nucleic messenger RNA vaccine. Then we have Astrazeneca, which is a viral vector vaccine. And we have Janssen, which is viral vector vaccine as well for COVID-19. So we have so far given four conditional marketing authorization for the vaccines which are developed by these four manufacturers. And I'm saying it because this is following EMA positive assessment of their safety and efficacy. So European Medical Agency is continuously monitoring the safety and efficacy and the data. We will discuss that data as well. So vaccination figures, these are the figures from last week, so they might be slightly different now, but I was preparing this from last week, so I would say that this is in general the vaccination figures. 88 million doses are delivered in Europe, out of which 62 million doses have been administered. So this is all about EU at the moment. So coming to UK, so these are the statistics which were published on, I think, 29th of March, because I took those statistics on that date. So number of people who have received the first dose of vaccination in UK between 8th December to the 21st of March. In England, Wales, Northern Ireland, and Scotland, you can see that the number of people who have received the first dosage. So this is what is the situation in UK. So UK is having a really good outreach of the vaccinations at the moment. And number of people who have received the second dose of vaccination in UK is also very high. So at this point, I would say at the moment, the statistics of UK when compared to Europe looks really good. At this date, estimated 10.8 million first doses of Pfizer vaccine and 15.8 million doses of AstraZeneca vaccine has been administered. And it's important to keep these figures in mind, because when you look at the data of the side effects, you have to consider that which vaccines were given and which vaccines were given more than the other, so that you have an idea of the impact of the vaccination as well. So 10.8 million first doses of Pfizer and 15.8 million doses of Oxford's AstraZeneca has been administered till now. And it differs from the number of the estimated people who are vaccinated because of the different data sources. But these figures are quite promising when it comes to looking at the vaccine outreach, I must say. So let us understand the concept of the vaccinations. So how does it work? So this is the concept mainly from the AstraZeneca, and I will talk about how does it work in the simplest language. So the vaccine is prepared. The virus is actually, we all know that the virus is studded with the proteins that it uses the proteins to enter into the human cells, which are known as the spike proteins, which is a tempting target for all the vaccines that are there in the market. The vaccine uses, what does it use? It uses a messenger RNA, which is a genetic material which our cells use to make proteins. It is fragile, so it is important that you protect this messenger RNA, because it is chopped otherwise into pieces by the several enzymes in the body if it is directly injected. So to protect this particle, it is actually wrapped in oily bubbles made up of lipid nanoparticles. So this is how the vaccine concept is, and this is how it is protected by keeping it at certain temperature, or freezing it to ensure that it is transmitted when while it is viable as well. After injection, the vaccine particles bump into the cells and fuse to them, releasing the messenger RNA. After the messenger RNA is released, actually it is destroyed by the cells, leaving no permanent trace. And some of the spike proteins that migrate to the surface of the cell, they stick to their tips. And the vaccine cells then get broken down, uh, and releasing some of these proteins as fragments, which the cells present on their surface. And these protruding spikes and spike proteins are actually recognized by the immune system of our body. So in our body, we have antigen presenting cells. From your basic immunology, you can remember that. And they migrate when the vaccinated cell dies, when a cell dies, these debris or these particles, which the cells contain, they have these spike proteins and protein fragments, and they are presented externally by these antigen presenting cells. So when these particles are presented, they are detected by certain cells in the bodies. They recognize these particles or the proteins, and then they initiate an immune response. This immune response is two ways. One, they activate other cells like B cells, which produces antibodies against these proteins. And the immune response is also against another cells. They activate other cells as well. So one is the antibodies production, and one is also activation of the other cells, which can directly kill the virus as well. So this is the simpler concept of how the messenger RNA vaccines are working. So this is the messenger RNA vaccine, which is currently in the market by Pfizer BioNTech. It is What does it made up of? What does it have inside? So it is a nucleoside modified messenger RNA vaccine encoding the viral spike protein. And as I explained you that it is covered with the lipid nanoparticles, which is kind of a transport mechanism for this active ingredient of the virus. There were questions that what else these vaccines have. Do they have any salts? Do they have any sugar? Yes, it has salts because we have to make sure to keep the vaccine pH close to the human cells. And it also has some sugar because it protects the lipid particles at a very cold temperature. These formulations are important to be considered depending on the type of vaccines, and that is why the temperature and all these things come into play. That depends on the technology of what technology has been used for the vaccine. So whenever you have such questions, you can explain it to your patients that this is what are the reasons of freezing the vaccine or whatever. Similarly, Moderna vaccine is also another vaccine, which is a messenger RNA vaccine. It is based on the same principle like Pfizer vaccine. It is also given 2 doses, 28 days apart, and it is also transported at -80. It has a full-length spike protein, again, with the lipid nanoparticles. Encapsulation is there, and it is also approved in many countries including US and UK and EU, and it is for individuals 18 years of age or older. So another vaccine type that is there we are using is AstraZeneca vaccine. So let us see how these vaccines work. So when I say viral vector vaccines, the easiest way to remember is that they have a transport vector. So something in this vaccine is actually another virus which is transporting, which is modified to contain the gene which is making a protein for SARS-CoV-2. So another virus, maybe adenovirus or some other virus can be there. So in this vaccine, we have adenovirus, which is actually containing the gene. But this adenovirus has been modified and it is not causing any disease. It cannot reproduce and it cannot elicit any immune response. So it cannot cause the disease as well. It is given as 2 injections in the muscle of the upper arm, and the second dose can be given 4 and 12 weeks after the first dose. This vaccine has demonstrated around 60% efficiency in the clinical trials, and most of the participants in these studies were between 18 and 55 years of age. Once this vaccine is given, it delivers the gene into the cells of the body. And these cells will use this gene to produce the spike protein of COVID-19 virus. The person's immune system, as we just saw, what is the immune system? It is your T cells, mainly antigen presenting cells. It recognizes this protein as foreign and produces antibodies and activated T cells to attack it. If later on the person comes into contact with the virus again, the immune system will recognize it. So there is a memory system inside our immunity, and these memory cells will recognize it and they will be ready to defend it against the virus. And as discussed, the adenovirus, which is a vector, in this vaccine, it cannot reproduce, so it cannot cause any disease. So this is the concept of the viral vector vaccines and how they work. Jensen, another vaccine, which is also a viral vector vaccine. It can be given to people 18 years of age and older. It is administered as a single dose IM. And in the trials, the vaccine efficacy is 67%. So COVID-19, this vaccine is a monovalent vaccine composed of recombinant. So I'm putting here focus on the recombinant part because this is important. And it is replication incompetent human adenovirus type 26. So let's not go into the details, but just remember that this concept is also the same, which you have in the AstraZeneca vaccine. But because of the certain formulation principles, it is given as a single dose. It also has a full-length spike glycoprotein in a stabilized conformation. And the following the administration of this vaccine, the glycoprotein of the virus is expressed, which stimulates both the neutralizing and specific S antibodies. So here I would like to tell you that when we talk about antibodies, that when you give the vaccine and the body initiates an immune response and you produce antibodies and also the T cells that can kill the virus. So these antibodies are important to remember that there are various types of these antibodies that are produced against a protein or a foreign antigen in the body. And these types depend on the proteins that are there in the foreign virus or foreign vaccine. And these antibodies are of different types. So when we look at the neutralization capacity of a vaccine or the immune response of the patient, the type of the neutralizing antibody is important, and the quality of the neutralizing antibody is important, and the quantity of the neutralizing antibody is also very important. And we know about it as immunologists, that how it is measured and how it is seen. So it's not only about having antibodies, but it's about having actually working antibodies. So for this vaccine, it is for individuals 16 years of age and older. It is also given intramuscularly. Okay. These are the facts that I wanted to discuss about the Pfizer vaccine, because there were questions last time, I remember, about the interchangeability of the vaccine with the other vaccine. For example, if you have taken one dose of one vaccine, is it possible that we can take another dose of another vaccine? So it is not indicated by the vaccine manufacturers. One thing. Second thing, most of the vaccines, including the Pfizer, it is not safe to at the moment in people less than 16 years of age. But to tell you that these trials are going on, and the plan of marketing authorization for the pediatric population that is given to EMA is up to 2024 because of the results of the trials that are upcoming. Elderly population, there is no dose adjustment which is required for elderly population greater than 65 years of age. So we should give this information to the people who are asking us questions about the interchangeability of the doses between the vaccines, about the pediatrics and about the elderly population. So coming to the side effects, these are very common side effects which we all know as doctors. Whenever we are given a vaccine, we get pain at the injection site. It can be slight fever, headache, chilling, chills, joint pain, slight nausea. These are the common side effects. But coming to the MHRA statistics about the side effects. So I'm sure that the NHS doctors are aware about how they are monitoring the side effects, and there is a yellow card scheme over there. I will just touch upon the Pfizer BioNTech evaluations that were done in the clinical trials, and how the data looks like of the vaccines from the trials, and how the data looks like in reality. So these are the most frequent adverse events or adverse reactions that were seen in the trial, which are common, reported in more than 1 in 10 people, and they were usually mild. So this is what the trials were reporting. These are the same reactions that we know, and they were reported less frequently in older people than in the younger people. In the Astrazeneca vaccine, in the clinical trials, which was having more than 23,000 participants, this was also almost the same. And the adverse reactions which were reported after the second dose were milder, and they were reported less frequently than after the first dose. So in this MHRA data, so MHRA is getting the data, and they are categorizing the data into two parts. One is the total reporting of the side effects, and then they are categorizing into fatal reports versus normal side effects. So according to them, these are the total reports of the side effects from BioNTech. So 40,000 side effects were reported, which are of different categories, coming from the headache to mild fever to joint pains to something in the blood or something here or something there, something in the joints. So these are the total reports. from BioNTech, and these are the total reports from Astrazeneca, out of which these are fatal, which are categorized in BioNTech and which are categorized in AstraZeneca. And they are continuously being monitored. You can see that there is a difference here in the fatal reports, because more doses of AstraZeneca are administered as compared to BioNTech.
Sister Zainab, a couple more minutes, and then
Okay.
we'll wrap up.
So I will go fast now. This is another side effect which has been monitored for the AstraZeneca vaccine. And I would like the doctors to be aware about it, that the British Society of Hematology is working on this impact, which is being investigated very closely about the thrombosis particularly in the cerebral system. And it is related to mostly thrombocytopenia, which is reported from some of the vaccines, including AstraZeneca. So this is another vaccine, which is a Sinopharm vaccine, which is inactivated vaccine. It is available and approved in certain countries, including Pakistan, which is conditional, I think, at the moment. And the efficiency of this vaccine, which is reported by the clinical trials till now, is around 79%. And it is a Chinese vaccine. And the clinical trial reports, both the young and the old people were included in the trials. This is another vaccine, which is Novavax, and it expects to receive UK and US FDA approval in the Q2. It shows very promising results. And this vaccine is a protein-based vaccine, subunit vaccine, so it is made up of viral proteins. And the best part is that this is showing efficacy similar to BioNTech and Pfizer vaccine. And there are big chances that there will be a very high demand of this vaccine, because this will get very soon the penetration into the EMA and FDA market. So hopefully we will have this vaccine very soon in the Q2 as well. It shows a very good efficacy of 96%, and the overall efficiency of this vaccine against the variants is also very good. So this is a good news for us. So where are the variants, and where do we stand with the variants? So these are the common variants which are identified. So I want you to consider the fact that the variants are made up of the different types of mutations that happens in the virus. Variants of concern is important. There are many variants of the virus, but these variants are defined as variants of concern by European medical agencies. And we call them variants of concern because of their transmissibility. Maybe they are related to increased severity of the disease, or maybe they have an impact on the neutralization capacity of the antibodies. So therefore, we call these variants as variants of concerns, which are identified in certain countries. Some of the vaccines are still working against these variants with certain potency. For example, the Novavax and also the Pfizer vaccine. This is my last slide related to if you need any further references, or if you have any additional queries, you can definitely get back to me. So this is the situation right now we have related to the vaccine and the vaccine variants and the side effects of the vaccines that are reported. So I'm available if you have any questions to answer. Thank you very much.
Thank you, Dr. Mukhtar. What a wonderful talk, and I would say perfectly pitched, as even as doctors, we don't know these basics. And I certainly learned so much myself. We're lucky to have an expert like you giving the talk. We're going to move on to the next talk, and I hope you'll hang around, because at the end, we'll do the questions on both talks. And so let me then, if you unshare your screen, and let me introduce our next speaker, and it's a pleasure to introduce Dr. Fatima Hussein. She's past president of IMI UK and current president of IMI UK Women's Wing. And I joined IMI UK when she was president, and it was her inspirational leadership that carried IMI UK in probably its most successful period. She's been a doctor for 30 years, is a consultant obstetrician and gynecologist in London and the surrounding counties. She qualified from King's College London, completed postgraduate training in obstetrics gynecology in London, and had intensive specialist training in the field of infertility and IVF at the Guy's Hospital Assisted Conception Unit. She's now lead for reproductive medicine and fertility, lead for female genital mutilation, associate professor in obstetrics and gynecology, and site director for the American University of the Caribbean and the site director for Ross University Medical School. She has done lots of official educational videos and patient and healthcare professionals across various communities. Again, please do post any questions on the Zoom chat and I'll endeavor to ask questions at the end of the lecture. But without further ado, we welcome Dr. Fatima Hussein.
Hello, Assalamu alaikum everyone, and thank you so much for such a kind introduction, Hussein. I loved Dr. Zainab's talk. I thought that was so detailed, and I learned a lot actually, and I've got more questions, and I'm going to be emailing her about pregnancy stuff. So thank you very much for inviting me to present over the next 15-20 minutes an overview about fertility, pregnancy, COVID-19, and some of the myths. The organizers, Anum and Hussein Shabi, and all the team with us are, as the president of IMI UK, and Hussein Raza as IMI EU lead. I'd like to thank them all because I think this is a brilliant forum. Now with COVID-19, we can all across the world be sharing all our expertise, and lots of people on these conferences. So thank you once again. Just want to say, because this is recorded, and it's always very important to make sure that the general public may view, people who are non-medics, and that's absolutely fine. I have geared my talk to an audience which will not be obstetricians, gynecologists. If there are, great, but general doctors, allied healthcare professionals, and members of the community, I hope will benefit from this talk. And just to say that these are very general statements, and I'm trying to make it as evidence-based as possible. And there will be some studies that I'll present, but they should not be quoted out of context. It's very important. I've taken a long time to read one of the papers, and I still have a lot of reservations about some of these studies. So with that opening remark, Bismillah ar-Rahman ar-Rahim, I'll make a start. Okay, so I've been asked to talk about the six, well, I put there's a slide, and I would like to acknowledge some of the slides I have taken from trusted websites. So this is from a children's health organization. So because the title of the talk is about myths, here are some of the myths that are out there about COVID-19 vaccine. And don't worry, I'm going to talk a little bit about the vaccine, a little bit about pregnancy and what happens with COVID-19 in pregnancy, and a bit about people who are trying for a baby who may want to have the vaccine and who should have the vaccine. So I'm going to cover like a general mix of things. So I think Dr. Zainab's talk has probably got rid of quite a few of my slides, because she has already indicated the myth that COVID-19 vaccine alters the DNA once you have an injection of the vaccine. mRNA vaccines, such as the Pfizer BioNTech vaccine, do not alter the DNA of the person receiving the vaccine, because the mRNA doesn't enter the cell nucleus of the person receiving the vaccine. So it cannot change the DNA. So just out, for the non-medics, I apologize. You probably all know this, but this is a message that we need to get through. Oh yes, and the other thing is, by the way, this is, I thank my mother for this, because she did remind me that a lot of people in our community, because this is a Muslim Shia organization, welcome to everybody who's Shia, non-Shia, non-Muslim, no faith. But in our community in particular, there is a tendency to say, oh, this is not allowed. Religiously, is this allowed? Is this valid? Well, look at the announcements coming out by the leading religious scholars from the Shia world, and you will see that it is allowed. In fact, the Islamic principle of preserving your health, looking after your body, and taking protection from illnesses is very much allowed, and it's encouraged. So just a little note there. Now, the other myth, it isn't safe because of a quick rollout. It's thoroughly tested and trials, but we'll talk about pregnancy because clearly it hasn't been tested in pregnancy. But because there have been quite a lot of vaccines, such as the influenza vaccine, which is a inactive vaccine, rather like the COVID vaccines, they are given safely in pregnancy and they have been tested thoroughly. Food allergy, immunocompromised, breastfeeding, or pregnant people can't get the vaccine. That is, well, again, let's just focus on the breastfeeding pregnant. They can, and we'll go into reason why people who are in that group, which particular groups should really go for it if they're called. Another myth, I'll get COVID-19 from the vaccine. The vaccine cannot give you the virus because it's not the actual live vaccine. I've had COVID-19, so I don't need the vaccine. Well, natural immunity length from the infection is not known, and so therefore the vaccine is still recommended to fight reinfection. Now, this is another myth. No need to have a mask or social distancing about after the vaccine. You must still take precautions to help end the pandemic because we don't yet know how long the protection lasts for. And maybe you were infected just before you got the vaccine. So actually, you might still be actually an asymptomatic carrier. So I hope that helps. And as I say, look, medics, I apologize. I know you know all of this, but this is hopefully shared for members of our community. I have taken the liberty of taking information and infographics from trusted sources, such as the Center for Disease Control in the United States. And you can see there it's saying that pregnant women may be at increased risk from severe illness from COVID-19 compared with non-pregnant women. And I'm going to present some data to say that is the case, particularly in certain groups and in the third trimester of pregnancy. So we must still take precautions to stay healthy and reduce the risk. And just another thing to say, the date for the World Health Organization declaring this a pandemic was actually the 11th of March, 2020. So therefore, we are only 1 year from this. And so a lot of the information out there was gathered during the height of the pandemic, in between the two waves in the UK, for example. I'm based in the UK. So a lot of the data kind of gives the impression the pandemic is still going on, and it is indeed still going on in some countries, sadly, Brazil, etc. So, you know, and even in Europe, in some countries, it's still quite a high rate. So just a few minutes to, again, look at the slide about CDC, Center for Disease Control in the Atlanta, Georgia, in the States. The people who were hospitalized with COVID-19 who were pregnant, a lot of them did have symptoms, but more of them were asymptomatic. So in many different countries, there are different ways of testing, and many places do not, if we look at it as a global thing, there isn't testing for everybody service, for example. So the guidance for COVID-19, this was produced again in the States when I think at the height of the pandemic, the ICU admission was noted to be higher for pregnant women, mechanical ventilation rates were higher, death rates were higher. So I'm just going to take a few minutes to go through this slide. This is produced, acknowledgement is to the University of Birmingham, the World Health Organization Collaborating Center for Global Women's Health, who have been doing a great job in producing ongoing research, which is updated regularly. This is from November 20, so clearly, you know, we're about 5 months ahead now, and things keep changing with COVID-19, as we all know. So what presentations of symptoms do they get in pregnancy? Well, it's very similar to non-pregnant, actually. So if we look down here, by the way, can somebody tell me if they can see my little mouse moving? Hussein, can you see that moving?
We can see it, thank you.
Oh, great, thank you. So cough, fever, breathlessness, muscle ache, diarrhea, and oh, I don't know what that means. Aguacia. Does anyone know? Oh, loss of sense of smell, maybe? Perhaps. Yes, taste and smell, I think. Lymphopenia, raised CRP, that's the commonest laboratory indication. 49% had raised CRP. And quite a lot of the pregnant women who presented symptomatically in the third trimester had radiological evidence of lung changes relating to pneumonitis. So it's quite a lot of women, 64,000 women, and they looked at all these studies, 192 studies from 30 countries. And so this is quite good, reliable data, I think. I am going to present briefly a research paper, which actually is a little bit old now, old and as in terms of COVID-19. It was published in June 20, but because there were 86 studies globally, and then they also took case reports, and for rare outcomes, they looked at 114 full manuscripts, and they also looked at national registries in 5 countries, including China, Brazil, UK, France, and Netherlands. They got quite good data about what happens in pregnancy with COVID-19. I'll just share some of those with you. And I apologize, it's not detailed enough. And those of you out there who are really good at statistics will note that there's a lot of heterogeneity, and the fact that this is retrospective data collection, and I don't think it can be taken as the final version, because a year on, I think you'll get much better data. So this is acknowledgement to the authors of this study. So I know Asma Khalil, she's a professor at St. George's Hospital, and lots of collaborators across the UK came up with this SARS-CoV-2 infection in pregnancy, a systematic review, meta-analysis of clinical features and pregnancy outcomes. So symptoms as presentation, we've kind of gone through most of this, but this is people who've got testing on PCR for the SARS-CoV-2 virus. So a lot had a cough and a fever, majority actually. And the ones who are symptomatic are very few. And don't forget, some of these people were only hospital admissions. So majority would have been having symptoms if it was related to COVID-19 admission. Some of them may have been admitted for other reasons, obstetric reasons. Now, this is a very important slide, because I think everyone will be aware about health inequalities and the fact that most diseases, conditions are affected by ethnic grouping, obesity, health inequality related to poverty, deprivation, other such factors. So this illustrates this very clearly, that there is a greater proportion of Black, Asian, and minority ethnic groups. 50% of the people in this study were from that group. And don't forget, this is a global study. So yes, I suppose you could, somebody from Africa wouldn't be a minority ethnic, but these studies are pooled results, but it's just showing you the proportion of people affected. Age is a factor, more than 35. Third trimester, which is, more than 28 weeks, 70% of those people were in the third trimester when they had this positive infection and were affected and admitted to hospital. And these are I think we've gone through this one already. So we've also talked about raised CRP being one of the major features. Just a note of caution here for the non-obstetricians. Raised D-dimer in pregnancy is a very common thing, and really I'm not sure, in the UK we don't use it to diagnose venous thromboembolism, but it's obviously done in many other countries, so it was something raised, but I would probably put a note of caution that is not a diagnostic marker for COVID-19. In a non-pregnant person, this is a diagnostic part of the diagnostic testing for venous thromboembolism. So maternal complications, I want you to just have a look at the co-infection. Now, you might be wondering why the denominator is different. It's because some studies, they used case reports and other such things. So not all of these are from the same sample, but have a look at the intubation mechanical ventilation. That's quite high, 3.4%. And oxygen support, so that would mean CPAP, 18.2%. ICU admissions, 7%, and maternal death, 0.9%. Now that is very high because in the UK, I mean, the maternal mortality across the world, it differs from each country, but for the UK, that would be about 10 times higher than it is without COVID. And as everyone knows, COVID-19 infection, whether you're pregnant, non-pregnant, gives you a high risk of clots in the legs or lungs. So anticoagulation was used. It should be really 100% there, but anyway, they found 50%. And the people who had a very bad outcome were the ones who were already on antiviral treatment, who were on intensive care, who happened to be falling into the older age group, who are more level of obesity and a higher ethnic group. Because not all the cases were delivered when this study took place, you will see it's only 50% delivery rate here. The two key things out of this slide is there is a higher rate of iatrogenic preterm birth, by which I mean delivering the baby earlier than 37 weeks for reasons of COVID, because to help, if the mother is very ill, you want to get the baby out, let her lungs work to their full capacity. And under 37 weeks and the cesarean section delivery, 50% almost. So these are the two main things for us as obstetricians we've noticed with severe COVID-19 infection. What about the baby then? Well, the stillbirth rate is 0.9%, which is, in the UK, it's about 1%. It's a little bit around the same figure as it would be for standard. So neonatal death rate isn't much higher. And the key question a lot of people worry about is there vertical transmission of COVID-19 from the mother to the baby, which means through the placenta. Not enough research has been done on that yet, but the majority of studies have shown that the babies can get the infection soon after birth or around the time of birth, but we're not able to prove whether it was related to vertical transmission, except by seeing if the antibodies are present on the cord blood, which we could test for. And I think those studies are awaited. So we're going to talk about vaccines now. I may just skip on to the other slides. How much time do I have left?
A couple of minutes, if
couple
possible.
of minutes. Okay, right. So why did we do this? This is nice and colorful because it's better than reading all that text. I don't know if can you see that? Can you read it? Or I'll just go through it. The positives of actually that's too complicated. Let's go back. Okay, so the JCVI, the Joint Committee for Vaccination and Immunization in the UK, has recommended two groups of pregnant women who should have the COVID-19 vaccine when they're called. So the first group is the people who have got CEV, which is clinically extremely vulnerable. Those people, for example, with solid organ transplants, such as a kidney transplant, or people who are added onto that list recently has been people who are in the very obese category. What else has been added on recently? Well, essentially anybody who's more immunocompromised than normal. So just for the non-obstetricians, pregnancy is a state of relative immunocompromisation because the mother should not reject the baby, and so the mother's immune system is a little bit suppressed compared to the standard person. So the pregnancy is already a state of relative immunosuppression. So anybody who's got severe risk factors, diabetes, for example, or other things to make them clinically extremely vulnerable should get their vaccine when they're pregnant. Gestation is to be confirmed with the individual healthcare professional. The other group who are health and social care workers who, because of their work, that they are actually more exposed to a higher viral load, So a greater proportion of them, they have a higher chance of getting the infection. And we've seen already that having the infection and being pregnant is not good, particularly if they fall into a high-risk group, such as being obese or being in the ethnic minority or BAME groups. This is really, I think this is a really nice infographic. This is from the Royal College of Physicians of Ireland. So I'd like to acknowledge that. But here, 14 to 33 weeks is when they said you can get this vaccination. And they've said about the things that I've talked about here and the negatives and the, let me just talk about the negatives, but everyone will think there's no negatives. So the negatives is people may be worried that this hasn't been tested on pregnant women. Absolutely, you should. That's why it's not recommended for all pregnant women. So because we haven't got the long-term data, but we know that similar vaccines such as flu is completely safe and it will not give you the infection. So which is why I think it's important for us to acknowledge that pregnant women may feel very anxious about it. But they've got to consider the risk of getting very ill with COVID versus the yet unknown risk, probably very few, of the vaccine. So what about breastfeeding? Yes, they can breastfeed, and this is World Health Organization practice. You should, women who've got COVID-19, basically they've got to just treat the baby as somebody who may get the infection from them, just like anyone else. But the breast milk will hardly contain any COVID, because it hardly, when we look at things going through breast milk, the proportion of infections is very, very low. But we do not know that for sure. So this is my final two slides. Will fertility be affected by having the vaccine? Well, I'm a fellow of the Royal College of Obstetricians Gynecologists, and they, along with the Royal College of Midwives, have issued statements saying that there's no evidence that COVID-19 vaccines will affect fertility, because actually the biologically plausible mechanism for affecting fertility is not really there in a scientific way. I mean, I've read a lot of stuff on the internet, and a lot of patients say, well, oh, they may affect this, that, and the other, but I haven't seen any data available that would suggest that they do affect fertility. And I can go into the details about fertility because I work in IVF as well. So we've got lots of rules about when people should have their IVF treatment, if they're having a vaccine, when they should have their egg collection. We are not stopping IVF treatment or fertility treatment and waiting for the pandemic to be completely over. People should not stop trying for a baby because of COVID-19. People should not stop trying for a baby because they're waiting 3 months for the vaccine course to be finished. So this is, I think this is second to last slide. And I think Dr. Zainab's slides will have gone through this, but this is a reassurance to say every vaccine will have gone through all of this. But for pregnancy, the pregnant women were not included in that vaccine data collection. And this is my final slide to thank the whole team, Anum Rizvi, Hussein Shabi, Mudassar, Huma Raza, and Shifa, all of you for bringing this meeting together, and hopefully we can have learned a little bit from each other.
Thank you, Dr. Fatima Hussein. What a wonderful talk, a very important talk for the current situation, given that the vaccine rollout is going to be rolled out to these younger women. And even doctors and professionals are worried about pregnancy and fertility in particular, given that we're getting to the younger ages. We are coming to the end of the meeting, so I'm sorry for those who have not been able to ask a question. I'm going to ask one question, and that's primarily to Dr. Zainab Mukhtar. And there's currently a lot of concern about the Astrazeneca vaccine in particular, but especially cerebral spinous venous thrombosis. And there's been a couple of questions around that, and I wonder what your insights or what your feeling is about that. Should people think about having that vaccine? Should people choose or wait? Or how serious is this? If you could unmute yourself and then.
Yeah. So according to the statistics, the risk is not outweighing the benefits of the vaccine at the moment. So this is the first thing that everybody should remember. And the side effect, this side effect has been reported previously by Pfizer as well, and now it is coming prominently in Astrazeneca. And I heard that it is in women less than 50 years of age as well. So let's first understand the concept of why it can happen in a vaccine. And it does not tell us to stop vaccination at all, because the numbers are very low at the moment and it is still under investigation about why it is happening. So first is why it is happening. When the vaccine is given, certain vaccines, because they have certain proteins in vaccines, and they initiate an immune response in the body. So because of the immune response, the platelets in particular are extremely active sometimes. And it is because the platelets do not have a nucleus, one thing. The second thing is they are so many. The third thing is that they are constantly being changed every 10 days. So they are more susceptible, one thing. The second thing is they have certain granules that release certain antigens, and these antigens sometimes elicit an immune response that can cause formation of antibodies. I give you an example because everybody is mostly a medical professional here about the treatment with heparin. So everybody who is undergoing a cardiology assessment or post heart surgery or stuff like that, you understand what happens when we give heparin to patients, and they are sometimes susceptible to have heparin induced thrombocytopenia. So certain medicines, when they are given in the body, they initiate an immune response in the platelets that can actually release certain antigens which react with antibodies, and the platelets are reduced. So first thing is that the platelets are reduced. The second thing is that it initiates an immune response in the body, which causes coagulation, which initiates coagulation cycle. And this coagulation cycle becomes more prominent in the cerebrovascular circulation because of the certain reasons, and also in this phlangenic circulation because of the certain reason. This is related to the biodistribution of the vaccine as well. So there are two factors that come into play. One is the biodistribution of the vaccine. One is why the immune response is happening. And EMA is quite actively looking into it. There are certain antibodies that are identified by Norwegian group that they are saying that most probably these are the antibodies that are related to this type of reaction. But the risk is not outweighing the benefit of the vaccine. It is very, very low at the moment. The numbers are not substantial enough to say that the vaccines are risky. Vaccine is not risky. So this is my message, and this is a message from all the regulatory bodies as well. We should continue to take the vaccines. Yes, there is a risk which is identified. We do not know the causal relationship of the risk at the moment, but doctors are being told that if the vaccinated people within the 2 weeks come out with certain symptoms, then they will have a guideline to investigate this. So people who are, we take treatment for cardiac diseases. We take treatment when we get sick. We take treatment when we have thrombosis in the veins of the legs or varicose veins or whatever. Vaccination is also a preventive treatment, and it is susceptible to have certain effects. And this side effect is not outweighing the benefits. So people who are listening, please monitor it. You have been given instructions by your regulators and your health regulatory bodies of how to monitor the patients after the vaccination. So follow that. And the British Society of Hematology also investigating this relationship. But right now there is no impact of saying or that we should reduce vaccination or there is any risk. This is one of the side effects which is identified and it is under investigation.
Great. Well, thank you, Dr. Mukhtar, for answering that. And thank you to both Dr. Zain Mukhtar and Dr. Fatima Hussein. I'm sorry to our attendees who I wasn't able to ask any further questions. And maybe next time we should have a whole hour to each of you, Dr. Mukhtar and to Dr. Hussein each, because of how interested, how many questions there were from the attendees. They're a wonderful topic. You explained everything wonderfully. Before I hand over to Sister Anam, who's our IMR UK and EU Secretary, tell us about upcoming events, I would like to thank all the attendees on Zoom and Facebook Live today, and our organizers today, and the speakers, and like to wish everyone a blessed upcoming Ramadan, and look forward to seeing you all for future events. I'll hand over to Sister Anam about some future events now.
Thank you, both Dr. Zainab and Dr. Fatima Hussein and Dr. Shabi for moderating our lovely talk today. I would like to just quickly remind everyone we have an upcoming event at 5 o'clock, and this is a recurring event for next 5 weeks, even during Ramadan. It's targeted at children 6 to 11, and it's called Hashmi Club's Ramadan Club. It's quite interesting. It's led by Mrs. Iram Jaffrey, and they have a set of topics they will discuss, and there are prizes towards the end of each Ramadan challenge. So if anybody's interested in that, just drop me an email and I'll be able to give you further details or a link to share with you. We also have another event regarding our Youth Wing, which is a recent addition to IMI UK. And yeah, if anyone wants to join for that, drop me an email again. There is a registration link in the chat on Zoom. If everyone can just go through it, it's much easier for me to send an email and a reminder regarding any of the events. So yeah, please just register using that link and I'll come back to you all. Thank you so much for today. Thank you, Dr. Zainab. Thank you, Shifa. Thank you, Dr. Fatima. And thank you, Dr. Hussein, for moderating us.
Thank you, everyone, and goodbye.
Thank you.
Salam. Thank you very much, everyone. Thank you.